Welcome to Direct Supply's webinar. We are excited to have the Interlayer team and members joining us today. The topic for today is Falls Hurt. Let's huddle up to reduce severity and frequency. My name is Savannah Ocasio, and I will be facilitating today's meeting. Please note, the information contained in this presentation is intended to provide general information but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should not act upon this information without first consulting with qualified legal counsel. Today's webinar will be presented by Ray Miller. Ray is the Director of Risk and Safety Solutions for Direct Supply. He has guided the development and implementation of residents and employee safety, risk management, and loss prevention programs. Ray has led the Direct Supply Loss Prevention Forum, a network of risk and safety professionals in the senior living industry. Ray has also provided education, training, and insight for senior living providers at all levels within a long-term care community. He has been a regular speaker at many national and state long-term care corporations and conventions, but his new favorite title is Grandpa. And now please welcome Ray.
Hello, everybody, and I appreciate your attendance. The title at the top is as important as the title at the bottom, Keeping the Care and the Caring Connected. That's the title I've used on many, many presentations. But we're going to talk specifically about falls. Falls hurt, let's huddle up. We'll talk a little bit about actually conducting huddles, but the other side of this is just we've got to attack both the severity and the frequency. And it's not like I'm going to say a bunch of new things because you have been working diligently for a long time, and that's a universal you. We still have falls. We still have falls with injury. And we continue to work on it. We continue to work on it. What I've actually done is to gather together a lot of ideas that other people have shared with me, and let's go talk about a few of them. That's the agenda that we'll follow, and we'll keep coming back to it, and you know right where we are as we progress through it. So if you had the opportunity to change one thing that would help to prevent falls, the greatest impact on preventing falls or reducing the number of falls and the frequency of severity, what would you change? Now, I'm going to fill the white spot with things that I've been taught by others. But I want each, even though we can't actually carry on a conversation, I want each of you that are listening to this to decide what you would want to change, okay? I'll give you about 3 seconds. So here's the first half of the list. More one-on-ones, more time spent with the resident, creating an interpersonal relationship. Lighting that doesn't have to be turned on in many instances, but sufficient lighting, and forget the fluorescence, that's hard on the eyes. Glasses that not just available, but they're clean. More staff, I'd almost put it in quotes, because there's always those who, no matter how much staff you have, they're going to say, we don't have enough, or we're working shorthanded. That's an opinion. That's not a fact. Assistance. Assistance how? Some of it's going to be hands-on, some of it eyes-on, some of it's verbal cueing. All of those kinds of assistance matter. They make a difference. More training. The question, for who? Who would be trained? How would we talk to the families? How would we talk to the residents? We're not just talking about staff when it comes to falls, because a big piece of this lies with the resident too. Reduced clutter, and I would put clutter in quotes, because if you ever walked into somebody else's house and found, wow, there's a lot of stuff laying around here, and yet when we go to our own home, we don't see it anymore. We don't see it anymore. So we have to be careful that we just haven't become numb to it. Toileting and meals, why relate the two? Because one causes the other. We know that. As you partake of food, other things begin to happen inside of your body, and there's a reality to it. We get into call lights, not answering them, things like that are part of this. Increased activity, and that's meaningful activity throughout the day so that they're actually using their physical energy up so that they are tired. They will sleep better. Thank the employees. Oh, my goodness, celebrate your successes. You've had a lot of them over the years. Make sure the employees realize that they've done a good job. We just need to, when you think of it, think of good, better, best. Okay? And let's make this a matter of progress. Get to know the people. Which people? That's management's knowledge of the frontline staff as well as of the residents, and the frontline staff knowing the residents' stories. Make steps more obvious. That's pretty important. And it's more than just lighting. It's color contrast. It's just like color contrast for the handrails. All of those kinds of things. Even when there's a surface break, if it's between your entryway mats and your carpet or your linoleum in your front entrance, there should be a color contrast there so they know where it is, that coefficient of friction is going to change for them. Remember to ask for help. Remind them every day. Talk to them. Every shift change. When you come in to talk to the resident for the first time, reassure them that you want to be there to help them. Assist devices, the walkers. I had my knee replaced a year ago, almost exactly a year ago, and I fell once because of my walker. And it wasn't the walker's fault. It was my fault. I didn't pick it up over an edge, a break that was there. Resident and staff education, Again, back to the life stories, quicker response to change of conditions, because this is their clinical status, their medical status, their emotional status. It's a continuum, and they are continuing on this journey. Assessments and reassessments, including their balance. Quick question for you. Who has a role in your community in preventing falls? Which department? Which shift? Which individual? We realize they all do. But I already stated that it includes the resident too. They have to make the right kinds of decisions. We'll talk more specifically about this in a little bit, but we have to be engaged with the fact that this is a universal effort, because that's the only way we're going to achieve universal improvement. Now, reality is we're all aging, and that hasn't changed a bit. What has changed about aging? Well, when we think about aging in place, you look at that place, it's a little different than the first nursing home I walked into back in 1985. Okay? Yeah, 1985. The height of the ceilings, the bookcases. Now, I hope on those bookcases there are no books for the residents on the bottom shelf. Even the way they're dressed. Yes, this is probably an assisted living kind of a setting, but even in our nursing homes, we're finding the same sorts of changes in the residents that we're admitting. What else has changed? Look at that, a 6-year difference just from 1960 to today. What is it, 50, almost 60 years? But that's like it's a year of increase per decade that's passed. A lot of change. Where we live, how we live, those are changes, but other changes that drive us, okay? It's the care and the services. Who's paying for it? That has changed so significantly. Who's paying for it? And that drives us too, whether it's the insurance company, Medicare, Medicaid, all of those different are private pay. But there's also different expectations. Mom used to run marathons. After she's here for 6 months, we expect, and then I'll let you complete the answer because you've heard lots of statements, but the idea of aging in place. And that's beneficial to the care providing organization as well, too. Well, when we think of falls, I want to push you back a few years to a book that was published 1997, Preventing Patient Falls. It's still a good book. There's still accuracy in there. And in there, James has split it up into 3 different categories of falls. Now, I didn't give you the categories. I actually gave you the description of it. So there's spills, clutter, cords, leaning on a curtain. You think, leaning on a curtain? Yeah, leaning on curtains, because we perceive it to be something else. Gait, confusion, balance, history of falls, which we all know that's probably the best predictor of falls. And then things like your strokes, your heart attacks. So there's your titles. The accidental, the anticipated physiologic fall, and the unanticipated. So in a court of law, which is the only one you might find forgiveness and understanding for, if you're taken to trial, or if you're arguing facts even to arrive at a settlement, which is the only one you have a chance at, okay? It's that one, the unanticipated physiologic fall, because those other 2 you should have known about. But even the unanticipated, because there's this concept in law of knew or should have known. If it's something you could have known had you done an assessment or those kinds, or passed information on to the next shift, then the reality is you're going to be held accountable for that one too. So as we continue through this process, I want to back up to the title for just a moment. Huddles. Now, you'll have these slides, you'll have this PowerPoint, and down at the bottom of every single one of them, you will find the source for the information that I'm using. These are good sources. The title of this one, I can read it, you might not be able to, is Effective Huddles and Debriefs. It's the debrief characteristic of a huddle that's so critically important. You've got to gather information. And if you look at those two little pictures up there, okay, we're looking for facts, but we want to pull together the right group of people. Why? Well, because we want to influence the critical thinking. How do we understand false? Because if you don't understand them, the chances of preventing them are very, very minimal. We need to decrease not just the number of falls, but the risk of falls. You will attack the number of falls and the severity of falls by decreasing the risk of falls, okay? The risk are the causes. We've got to dig down to the causes. And then you're looking for enterprise-wide changes too. Yes, with the individual, but where else in your facility, in your community, do you need to make the same or similar changes? And the bottom line of this thing is if we don't work together as a team, if we don't collaborate, coordinate, if we don't go after this as a team, we're limiting our ability to actually solve it. Now, let's talk specifically about characteristics of huddles, okay? A couple of things. You want to have the one immediately. The fresher the information, the better it is. It gets stale is a term that you'll see used for it. But then you also want to back out about a day later. And the other thing is you want to be in a very similar situation. Don't be off in a conference room somewhere when you're talking about this, because you want to be in the mindset the resident was in as best you can. Who should you consider? Number 3, who should you consider for participation? And you see that symbol at the end. If you notice, my slides tend to all cascade, okay? I couldn't cascade that one if I put pharmacy in there. So you got a symbol for pharmacies. But you also want to think about number 4, the family, the resident. Okay, and you want to know what they think. And you got to be careful with when we talk about a huddle, you don't want to dictate how the conversation goes. You want to facilitate that. And it needs to be a discussion that's blame-free, and then you celebrate your successes. Now, that's the second time I've used the term celebrate because it's really, really important that you recognize people for all of their accomplishments. Pat them on the back. Let them know what a good job they've done. You tend to encourage them to do more. So now we're changing topics. Okay? Now we're going to go on and take a look at claims, costs, and considerations. So let's talk about your analysis. I wish we could. I wish we were in a setting where I could ask you, what have you found? But these are things I've been taught that others have found. Let's see how they fit for you. How many years, what age do you start seeing significant increases in numbers of falls? Well, 75. Okay, why? Because we start talking about frailty, sarcopenia, balance. All of those kinds of things really begin to decline, particularly for those who have begun to limit their activity level. Now, this is going to be an interesting one. I'll bet you haven't thought about this one, okay? The majority of our falls occur at what month of residency? When you admit a new resident, when do you tend to see increases in numbers of falls? 5 to 6 months. And you're thinking, what's the empirical evidence behind it? I don't know that I have specific empirical evidence, but I have stories and I have been told of examples. And the idea behind the 5 to 6, I think it has something to do with the fact at that point you realize you're not going home now. You're going to be here for probably the duration of your existence, okay? So maybe a little depression, maybe you don't have that target, you don't have that goal anymore. Those kinds of things make it different. What percentage of our falls occur between daylight hours? Yeah, the hours most of us are awake. No surprise, 3/4 of our falls happen there, but you still have some that happen at other times. So what kind of things when you do your analysis should you be looking for? Nothing new there. Frequencies, patterns, trends, correlations, causes, and then take a look at what interventions have been put in place and why weren't they successful to begin with. Now, here's a little bit of a word puzzle, okay, or a word equation. If you have increasing frailty and increasing needed assistance with ADLs, what begins to happen? Yeah, your falls increase. How much more likely? 3 to 4 times more likely. So the reality is it is a reality. If we're not careful, we're going to have increasing falls. Why? Take a look. You can read the parenthetical. People begin to weaken, balance begins to decline, and so consequently we end up with those challenges. But here's some corporations learning about falls, okay? And this is talking on the claim side of things. Somebody made a claim against this corporation. Medical malpractice, that's where there's a resident injury involved in this, okay? And most of those are settled. They're not tried. We're afraid, and we're afraid of and we run from the facts many, many times, and there's wisdom in that a lot of times. Because it doesn't take much of a lever for the plaintiff's attorney to turn this into a nightmare for you. So their experience, they had their average cost for settled false claims. We're not talking about anything that was tried. These are the settled false claims. 3-year period of time, they had 41 of them, and it cost them on average $137,000 per claim to settle. And actually, their frequency was lower than the national average at the time. So they were doing a good job. And I'm not saying that necessarily that frequency drives severity, but if you never had the claim, then you didn't have a severe one either. So let's compare those two numbers now, okay? Settled false claims, and that's going to be the $137,000 per claim. That's over $5.5 million. Think about that. How long do you work for $5.5 million? A long time. What about your activities budget? I'm not saying this is yours, but this is a real activities budget. 4/1,000ths of a dollar a day, 4/10ths of a penny per day, per patient bed day. And now I played with the 94 because I wanted this to work. So this isn't even a great big facility. But if you use that 4/10ths of a penny per day for your budget for activities, that's not payroll, and you have 94 residents, that's 38 cents times 365. There you've got your $137 a year annual budget for those kinds of things, for new and increased and improved games, activities, that sort of stuff, okay? And you can see where I'm going with this. 137,000, 137, what are we going to do with it? All right, a little bit of math. It costs you 1,000 years of the average activities budget to solve to settle one of those false claims. That is a big deal. That's only one of those claims. You take 41,000 years of your activities to close all of their claims. And that means you would have no activities. You'd have more falls, by the way, too, because that's just the way it worked. The less activity we have, the more we fall. Now, I want to take this concept one step further, okay? Just one step further, because I want to talk about what's happening between the comparison of the assisted living experience and the skilled facility experience based on lawsuits, okay? Now, any guesses who I'm talking about when I say the sharks are circling? Yeah, the attorneys. And I hope I'm not offending anybody, but you can't get at me right now anyway, because this is a recorded presentation and I'm remote to you. So, actually, it's happened already. In some parts of the country, okay, in some parts of the country, the assisted living litigation is now more expensive than the skilled nursing facility litigation. And you're thinking, oh, Ray, you're just making that up. That can't possibly be true. That would never happen. You just said it for theatrical effect. No, it's a reality. Why? Why? Well, the other reality is that the attorneys, that entire industry has learned an awful lot through their processing of the nursing home claims, and they're not going to have to relearn those lessons. They already know them. They know how to come after you. I could tell you about that first claim that was productive, and I'll tell you this much. It wasn't because of the facts, the clinical facts of the case. It was because of contract law that they were successful in their lawsuit. What am I talking about contract law? It's the promises we make. Okay? We all make promises as we're touring families, as we talk through these kinds of things. What kind of things do we make promises? Now, notice that I capitalized you, because I realize it's probably not the people on this phone call, but whoever is doing the tour. They're talking about the quality of life your loved one will experience, or the quality of care, the choices they're going to have, and the dignity and the privacy. We're talking about, we're setting expectations that will be perceived and defined in a court of law as an applied contract. Okay? Now, here's the reality. I could have put this in bold red. You probably won't be sued for your standard of care. Your standard of care is probably doggone good. You've been at this for a long time. You care about your residents. You care about your staff. You care about the outcomes and your success of your community. What you will be sued for are your mistakes, errors, and omissions. See, again, I capitalized your. You're not the one making those mistakes, but you're going to be sued for them. I want to show you two pictures, okay? Because it's talking about contract law. If I were to ask you, what is the facial expression of that shark? What is it? He's smiling at you. See that? The only time that shark, and the sharks at the top we were talking about, stops smiling at you is just before they bite something. And then they eat you up, and things change, and it's bad. So here's your test. What is a non-economic damage? So it's not the cost of medical care for the fall. It's not the loss of consortium for the fall. It's none of that. What's a non-economic damage that the residents experience with or without a lawsuit? That's fear of falling. You've seen that. It will lock them in bed like handcuffs. They will not get out. They fear a couple of things, okay? They fear the fracture, and they have this fear of actually falling again. And see that picture up there? It's a great picture, great image. You can go out and find it. This is a man walking uphill, resident age. He's got his walking stick, long strides, all of those uneven surfaces, loving what he's doing, okay? Loving what he's doing. Now, there's a paradox here, okay? And it's an important thing that we all, I think, realize it already. The more sedentary you are, the more deleterious it is on your health, okay? Sitting still does not prevent falls. Sitting still makes it even worse, okay? Makes it even worse. Couple of facts. Fear of falling is powerful. It makes you limit your mobility. All right? But it's complex. You have been dealing with this for a long time. Lots of caregivers have been dealing with this. It's not like there's a simple solution. But the other thing is balance can be improved. With more time, I could show you program after program after program. We're only going to talk about two. Program after program where they can show improvements. We can teach people how to recover their balance. After they've lost it, we can teach them how to regain that. Okay, Phoebe Hanks, she said, like many other studies, ours found that the more fear you have of falling, the less likely you are to go out for a walk or just be physically active, engaged, participating. All right? There it is. It's a vicious cycle. The more you restrict your activities, the weaker you become, the more likely you are to fall. And on that goes. All right. So this is a slide that I got a long time ago. And this is a lady who was bedbound when they admitted her to the community. This is an assisted living setting. And the occupational therapist looked at it, the clinicians and the therapy talked about it, and they decided, we really can't see a reason for this. Why would she be bedbound now? So they set upon developing this program where she could walk again. She learned how to walk. She learned how to gain balance. She gained confidence. She gained stability. And, she began to participate. She participated for 3 years. She went to the mall. She participated in congregate dining. All of those kinds of things began to happen again in her life. And then towards the end of that 3 years, she fell and she broke her hip again. Now, was that worth it? And I have asked that question in probably 50, 60, 70 large audiences, and I have never had anybody say, no, that's not worth it. The reality is it was worth it. And by the way, the rest of the story is the picture you're looking at right now is after that broken hip. She would not quit. She would not stop. She came back, and she continued to live out her life. What changed inside of her? Her desires, her confidence, those kinds of things that come from good interpersonal relationship activities. Having a staff that she knows cares about her, caring about the staff. Now, I want to show you a new image. That's why I slid this stuff to the left. And I don't know if you can see what this is without me describing it. That is a downward spiraling staircase. Because if we don't help them make those kinds of changes, that's what we get on. Now, I want you at a future time to take a closer look, because you can see somebody's hand on that stair rail, and what direction is that person heading in. They are coming back up that staircase, okay? And I'm not saying we can necessarily do that, but we can certainly put it on pause. We don't have to continue. With this whole idea of aging in place, what disrupts our plans of staying right where we are? Two things: unmanaged progressive conditions, or the trauma. There's some of the potential unmanaged. And what's the primary source of trauma that we're going to talk about, especially in this presentation? It's falls with injury. Now, the reality is that normal aging process, sometimes we blame it all on that normal aging process. It's really not the normal aging process that causes it. It's the idea that there's these unprogressive conditions or somebody gets injured, okay? Yeah, the normal process exacerbates the speed, but it's not the cause. And I don't care whether you think of this as the dominoes that just lined up, and once the first one falls, everything falls, or you do think it about that spiraling downward staircase. The reality is we need to figure out where we can put our hand in this and create a difference and put it on pause, maybe even stop some falls, okay? We slow things down a little bit, because there's a reality to us. We can be effective. I mean, you've been making good changes with good programs. Okay? I want to talk about now nursing home common causes of falls, but then the next slide will be assisted living common causes, okay? Muscle weakness, walking gait problems, environmental hazards. You can read the parenthetical. I hope this isn't the only time you watch this. Drugs on the central nervous system. We've done a lot of attack on that one. Everybody has. Poor foot care. That one sort of surprised me. I didn't realize. But now that I've had some surgeries and I'm going down this path, I retire, and just in less than 2 months, I realize how important comfortable shoes are. Okay? Significantly important. And dementia increases the risk of falling and the risk of injury. Okay? Now, let's take a look at the assisted living. A few more things, but you'll see the interrelationship here. Medications, yes, walking and gait problems, including the comfortable shoes. Depression, sleep deprivation. You could do an entire presentation just on the significance of sleep deprivation and the frequency of falls. Cardiovascular challenges. Vision. It's not just that they have their glasses on, but the glasses are clean and comfortable, okay? And that there hasn't been further decline. Chronic and acute diseases, the muscle weakness, but also the environmental hazards. We've got to prevent those kinds of things, okay? Hope that all makes sense. Now, I want to go take a look at what the staff sees, okay? This is one of my favorite pictures I'm going to show you, all right? We have 5 children. We have 24 grandchildren, and our oldest grandchild is actually in the oven. Our first great-grandchild is actually in the oven baking, okay? And I love that picture. What does the staff see? What are they aware of? What do they respond to? I think of it as clues and cues, clues of changing conditions. Something going on. Scan down through those 8, okay? Who's probably going to see it first? Who's closest to see it first, okay? Frontline staff. And then I think of, and it's my own idea, okay, itchy vigilance. Probably every single one of you has scratched your ear, adjusted your glasses, repositioned yourself in your chair as you sit here and you watch this. That's itchy vigilance. There was an impact and you made a change, okay? That itchy kind of a change. Okay, I'm going to do something about it right now. Because the reality is, the earlier we identify those changes on the left, the sooner we can do something about preventing the fall. Good program out there. We don't sell this, so don't think I'm marketing to you, okay? Aegis Therapies. It's called the WALK program. And they talk about a lot more than just falls, okay? They actually have 7 dimensions of wellness in their program. And we're going to look at them, okay? We're going to look at them. I'm not going to talk about them at length. I want you to get back and I want you to think about them. You can go out and Google this and you'll find the same thing that I've got up there in front of you. Physical wellness. Yeah, you got to keep walking. Intellectual. I'm a steady student. all right? But different kinds of games and mental games and brain teasers and conversations, okay? That's got to keep going. Emotional wellness, spiritual wellness, occupational wellness, social wellness. What the heck is social wellness? Emotional wellness. The idea that I participate still. I go out, I'm in congregate dining, I'm doing those kinds of things with those around me. I'm still engaged in living and the environmental wellness, okay? What kind of things am I going out to engage with in the environment? Got to keep moving, okay? We've got to keep moving. And I'm not saying to the next slide. I'm saying as a resident, I've got to keep moving. There's this whole idea that Terry Evans taught me about. It's called critical mass, okay? And what it amounts to, we've got all these systems in our body. They have extra power within each one of those systems because at times when there's sickness or there's injury, those other systems that weren't sick, that weren't injured, they've got to help compensate for the weakness or the sickness in the affected systems in our body. But what begins to happen? Okay? It's just like this string. This rope. It was much, much stronger when everything worked together. But at some point, there's going to be a decline. Now, I want to take this one step to the side. I want to talk about another kind of a break. All right? If you have any kinds of lifts in your community, I want to plant a seed in your mind that when you walk in and you see a sling, you pick it up and you look at those straps that attach it to that lift, because that's another kind of a fall. We're not here to address that necessarily in its complete package, but I want you to think about those. I don't want you to walk past a sling without looking at those straps. And you're going to find you need to get a pair of scissors and cut the straps off of some of those because they are broken. They should not be used. All right, when you think of critical mass, I want you to imagine all of those systems around there, and they're interacting, and they're supporting, and they come together, and they create this critical mass. When that declines, then we have frailty beginning to increase, okay? And this is just sort of this scale of frailty. And I think those pictures are very, very, very descriptive. My mom is 88 years old, and she's still on number 3. She's managing well. She drives. She just came back from a trip to Europe. She took her 3 daughters. Yeah, she left her 2 sons behind, but she took her 3 daughters, 10 days in Europe, okay? No Kenya, but it's going to happen. Those kinds of things begin to happen. That's one of those areas we need the staff to be aware of. We need to make sure that they see it coming. And it's easy. It's just like that clutter we can ignore the clutter. Well, this is another kind of clutter that we need to make sure that we have awareness of. Now, I want you to think about frailty from the position that getting breakdown. Systems begin to break down. And there's kind of multiple things here. Okay, take a look at it. And we're saying that if there's at least 3 of those, that you've got frailty beginning to develop, okay? So it's not any one just declining, but it's over time. Now, I don't know how many of you recognize that man's picture. His name is Jack LaLanne. This is when he's 73 years old, okay? 73 years. I want to show you a picture when he's 93. If there was anybody that was going to ward off frailty and decline, probably would have been Jack, all right? But it didn't happen. It didn't happen. So now let's go change topics on you. Let's talk about assessments and interventions. Start with assessments. Multifactorial processes. I love them. Oh, I'm so grateful for multifactorial processes and assessments. Why? Because I fly commercially a lot, and you know what? That's a pretty plane. It's a Beechcraft. I think it's a 172. But here's the checklist, okay? They go look at all of the systems before they make the decision that, yeah, let's take this plane up into the air, okay? And back in the 70s, there's big challenges with the frequency of aircraft accidents. One of the biggest changes in it were their checklists, their systems, their assessments. We can do the same thing when it comes to residents. Now, what kind of things would we assess that resident for? I think it's pretty cool looking. That's actually me. No, it's not. But it could be, okay, in a few years. So let's talk about things like the stuff on the outside, the environmental or the extrinsic kinds of things we need to be assessing. Take a look. Yeah, scan down through it. Those are the things outside of that resident's body that really become contributory if we don't assess them and make sure that they're correct. How about the clinical on the inside? Yeah, I'm not even going to read them to you. You know what they are, okay? You know what they are. But how do we spot them? Multifactorial, we're going to look at the history. We're going to take a current physical examination, but we're not just examining the physical side, okay? We also want to look at how it functions, their ADLs, all right? And I commented earlier, what is the best predictor of a likelihood to fall? It's the fact that they fell in the past. But let's look at their meds. Let's look at other risk factors. Okay, have there been surgeries? Has there been a decline in eyesight? Physical exam, you know those things. You know them better than I do. All right? Absolutely. We've got to make sure that those are in place. I've often asked, how many assessments do you do on any given resident in a year? And I just get this head shake. It's this dumbfounded. We don't know, but it's ongoing, and it needs to continue, okay? But let's talk about physical. Just because they decline physically and we find that their ADLs begin to require more assistance with it, that doesn't mean that they're ready to fall, because there's lots of things we can do to help them in the process so that they don't continue to decline quite as rapidly. How do you prevent falls? We're going to look at 6 pieces, 3 at a time. It's just 2 slides. We talked about the assessments, the interventions, and I want you to think 3 categories of interventions, okay? 3 treatment, rehab, and environment. How about methods of assessments? The interventions are going to be determined by your assessments. Multifactorial, interdisciplinary. You got to work together as a team. Where do you engage the interventions? It can be with the patient. It can be changes in how the staff works, but it also might be organizational changes that you need to make. Maybe it's things like it is lighting. Get rid of the fluorescence, okay? Please get rid of the fluorescence. Make sure there's color contrast at important points in their environment, but education as well. Education about what? Specifics to a given resident. Hey, Mrs. Smith, make sure you have your shoes on. Okay, socks are not shoes. And then prevention strategies. I want you to make sure that you hold onto the rail every time that you're walking down this part of the hallway, okay? Now, my wife and I did a prevention strategy 4 years ago, Christmas 4 years ago. We promised each other, because we had a large set of oak staircases, or a large set of staircase. And we promised each other that up or down, we would always hold onto the handrail. And you know what? You have to make those kinds of strategies. You have to be engaged with them. You have to buy into them. Or you have to remind your residents that they continue to be necessary. Okay, and remind them what they were. They might not remember, but you need to. And don't just do it once. Every time you come on shift, you want to remind them of those key elements. We're going to talk a little bit about that. Okay, I know exercise is a swear word, and I don't swear. But for some residents, it's a swear word. But it's important. That's how we retain our strength. And there's a difference between strength and capacity. Strength and the ability to go up the stairs, okay? Teach residents what? Their behavior strategies. What do we need to change? What do I need to continue to do? I just need to stay away from some situations, that kind of stuff. Yes, we can apply those other kinds of parts and pieces listed in C. Absolutely. And they have gotten much better and much more effective as time has gone by. Medication is probably the one I need to beat the least. Okay, but I have as a risk manager, I have, in a safety guy, I have so many examples that we could fit into here, okay? And the environment, we've talked repeatedly about the environment. But it's something as simple, because I saw a new install where the grab bars were exactly the same chocolate brown color as the wallpaper behind them. Didn't work. Somebody missed that, okay? Now let's think about it this way. That holistic caring, I want to compare it to a stool. 4 significant areas to think about, okay? Upper and lower weakness, presence of edema, range of motion, and levels of pain. And we're going to put those 4 on the 4 legs of the stool. Now, the reality is, if one or more of those functionally decline, that's this little word phrase up there, then the risk of falls increases, and it's almost geometric. Okay? So we just need to make sure that we have the interventions that are going to make the difference. More time, I'd give you a really good example of tactile sensitivity, what a difference it made in a man's life, but we don't have time for it. Let's talk about interventions now. When there's a fall, you want the staff to get keyed in on some responsibilities they have. Okay, absolutely stay with the staff and call nurse. You need to get the assessment done, whatever your process for doing that. Then a process begins. Immediately, right now, are you okay? What were you trying to do? What's different today? You didn't fall yesterday when you were doing this. What changed? Then we're going to move on. Where did this happen? What were they near? Was it near a toilet? Was it near a couch? Was it near a table? Was there a change in the coefficient of friction? Was it between a carpet and a linoleum area? Okay, what body parts? Were they sitting somewhere? The environment, we've talked a lot about it, but now think about how noisy was it, how busy, how cluttered. Because we're also talking noisy, busy, cluttered, lighting. That can also be things like floor care at night. Those kinds of parts and pieces will make a difference. What about the height of the bed? There's better height. Taller people, they can be higher. Lower people, they should be lower. Flooring, out of those things. Is there water? There doesn't even have to be water. Have you ever tripped over nothing? I have. Okay? Carpet has a better coefficient of friction than tile does, but that doesn't mean that it's necessarily better, because if it's a long shag and I'm not lifting my feet up as high as I used to, the reality is that I'm probably pretty likely of a fall. All those, the word transition is talking about that break between coefficient of friction, the tile and the carpet. That's an example. What kind of shoes do they wear? Are they non-skid? Okay, poor fitting clothes, things that are too tight, things that are restrictive. What kind of devices should they have? Because we could do root cause analysis, and we could do care planning. We could point out the fact that, some residents refuse to use the walker. They don't want to be perceived as being needy or declining, getting older. All of those kinds of things are important. We need to deal with them. Was there anybody present to see the fall? Okay? Those kinds of things are what the staff should have in their minds, because when you actually go and do your huddle, these are the kinds of things that we want to be following up on. Now, when we talk about post-fall assessments, yeah, we got all of those. We got all of those. What's one more here that we haven't mentioned? Okay, and for me, it's going to be talk to the resident. See what the resident remembers. See what make sure you talk to that resident, because that's an assessing person as well, too. When it comes to interventions, we're going to do the assessments. You come up with the interventions. Your assessments, what are some assumptions that you're going to make at the get-go with a newly admitted resident? One, they're at risk for a fall, and two, because of that fall, there's a risk for an injury. And I don't care when you do your assessments. I don't care why you do your assessments, but they need to be in-depth, multifactorial, and interdisciplinary as well. When you create the interventions, you've developed them because you now have the information to do that. You educate and you make sure that people are aware, not just the staff member, but the resident and the family. They're aware of those findings because they need to change their behaviors as well too, including that resident. Again, we've mentioned this multiple times. This isn't just about what the staff does to prevent falls, but it's about what the resident can do too. When you think of interventions, there's two kinds, standardized and customized. Standardized, handrails, perfect example. Customized, foot care, a change in medications, their eyeglasses. Okay? And when you think about interventions, I want you to think about the fact that there's strong, medium, and weak. Real quick. Weak. Okay? Weak. Well, it's just based on somebody remembering to do something different. What kinds of things, policies, all of that sort of list. You see the 6 items up there. What about intermediate strength interventions? They still have to remember, but you're going to provide reminders, readbacks, all of those kinds of parts and pieces that help someone change their behavior. But you're still leaving the condition there. The strongest is when you actually change something in the environment, in the process. What kinds of things? There's an example. Even down to that 3B. It's now legal to have two magnetic locks in the path of egress. What are you talking about, Ray? A lot of times we would have a dementia care unit, a dementia care wing on the second floor, and there has to be a fire escape, and you can only have one magnetic lock in the path of egress, so you would actually put that on the floor, the door at the bottom where they exited to the outside. It's now legal to have them at that top door so that the resident can't even get in there to begin with. What about pre-event interventions? I don't know about you. I actually have a video with more time I would play it of people yawning. And I get about, I don't know, a third to half of the people in the room that yawn because I show them that video. Is that the only kind of thing that creates this urgency to do something? No, it isn't. What about when you hear running water? Oh, latchkey urgency. I'm almost home. It's been a long drive. What begins to tell me, dude, you better address me right away? It's the bladder. Proximity urgency. I'm walking down. I know I'm close to the bathroom. Oh, good grief, somebody's already in there. But then there's this one too, the suggestion urgency. Hey, Mrs. Smith, do you need to go to the bathroom? And Mrs. Smith says, no, I'm okay. What should you do in about 5 minutes? Maybe even less. You need to go back, and now you need to take her to the bathroom. You planted the seed, the bladder begins to constrict, and it's going to happen. Okay? Hope that makes sense. I hope that makes sense. It's kind of a fun kind of a thing to think about, but it's not fun when you think of not doing it. So let's talk about that daily contracting concept where you're going to remind the residents every day. What kinds of things, okay? Verbal contracting. You just, hey, Mrs. Smith, and I already shared the examples. But then how about with the family? What kind of things can we remind them about, okay? You know what? There's nothing wrong with that first to do. Mrs. Smith, I care about you. I don't want you to fall. We're a team. That's a good sentence to share with them. Resident, hey, you know, your mom just had a med change. Here's the kinds of things we want you to be watching for while you're visiting her. Here's a longer list, though. What other kinds of reminders? Scan down through that. I hope somebody takes some notes. I hope somebody thinks to themselves, I'm going to come back to this slide because there's pieces here that I want to make sure that I can carry forward. All right. A real quick pause, but let's go talk about helping residents that have dementia to avoid falls, because I was asked that very specifically after a falls presentation. So we've got a number of approaches that we're going to talk about here. So first one, your traditional methods, activity, strengthening, range of motion, engagement. That's still very, very valid, very, very important. How about reconnecting with the resident and their life story? Help allay their fears so that they're willing to get up and to participate. Again, I care about you. If you spend time with that, you'll save time with other things in the future. Okay, and that isn't a far distance future. That's before the end of the day, you'll be glad you took the time to talk with your resident. Now, what are they willing to do right now? How can you determine that? I mean, if you walk in, because, you know, if you've got the resident who's they're not getting out of bed much, well, what if you propose to them, hey, can you help me with something? Can I get you to get up and move over to the chair so that I can change your bed? Now, have the bed sheets hanging over your arm, too, so that they get the visual cue as well as the audio cue. Let's talk about an extension of that one, okay? Can you help me? And you can see the words, find, with, bring, assist. How about even, hey, can you walk with me? I want to get on to Mary in administration. Let's go take a walk, okay? If you have more patience, it can result in more, with your residents, it can result in more participation of your residents. Number 5, visual cues. I used one as an example. Have the bed linens hanging over your arm. Okay? How else can you demonstrate? You can do side-by-sides. Don't use a lot of words. When you're talking about somebody who's struggling with the onset of dementia, don't use a lot of words. Show them. Side by side. Sit on the bedside with them. Show them how to get up. Those kinds of principles. And then continue to remind them even with the more familiar kinds of things. All right? Like tying your shoes. Maybe you just have slip-ons, and that can be even better. Maybe how to hold on to the handrail. Maybe making sure that when they walk into their room, remember to turn your lights on and show them, turn them off, turn them on, turn them off, turn them on. The seventh one, what a good technique too, because if you have activities they're interested in doing, and by the way, I never played bingo before, so don't try to get me to play it once I'm your resident, okay? Have meaningful activities for them, things that they're interested in doing, things that they want to do. It's a facility thing. If we're actually going to be effective with this, we're going to work together on it. Okay, how do you create the team? Therapy should be communicating the therapy goals to nursing so that we can work together. We can have reinforcement. Okay? The resident should always wear their footwear. And what kind of footwear? Whatever the therapy wants them to be wearing is probably the footwear they ought to be wearing throughout the day. How about care planning approaches? All right, you can build that into the care plan, whether it's strengthening exercises or make sure that we use if you've got someone that's declined even further, make sure that you use the gait belt and the walker when you take them out for some of their walking. Make sure that when you do your care plan, you ask the resident, you involve them, you engage them, okay? And if it's a newer resident, you need to make sure that you're talking to them specifically about what their experiences have been. We're going to go talk about training just a little bit now, okay? All right, what kind of training? Socks are not footwear. Call before you fall, but it can't just be a phrase. It can't be this nice, trite thing that it rhymes, so I'm going to say it. It has to change my behaviors and the residents' behaviors. Because if you don't call, you know what's going to happen. They're going to get up on their own, and then you have increased falls. Okay, falls prevention training, it's not just during orientation. I mean, honestly, I'd carry a pocket full of those mini Snickers bars. Yeah, I talk a lot about using Snickers bars. I don't even eat them. Okay, I love them, but I don't eat them. And you ask staff questions. And when they get it right, flip them one of your Snickers bars, hand it to them, and say, thank you, well done. All right? Watch your toileting schedule. And if you have residents, you realize that your phone has 24 available alarms on it. All right? You're going to have 24 different alarms set that can help you remember to go remind the residents so that they can remember too. Things you need to teach your residents. Consequence. You know, if you fall, you might go back into the hospital and think about the burdens that it creates for your family. And what if you have a head injury? That can be a long-term placement. You may never come back to be with us anymore. Trade-offs. A bed wet can be changed. It's okay. A wet bed, not a bed wet, a wet bed. Fractured hip can take months and months and months, and we all know what can happen with some fractured hips too. Independent transfers, you love to be doing things yourself. They'll be even harder. And your role as a resident, just stay out of those situations. Don't walk without your shoes on. Don't walk without holding onto the handrail. And if you've got to go downstairs, make sure you hold on. Take the elevator. It's a good behavior change to encourage them with, okay? And what do you do if you do fall? See that little star there? We're going to watch a video. Fall so as to reduce your injury. And you're thinking, that's crazy. How do I do that? Well, here's this 95-year-old guy, just like my mom, 88. She's still out there teaching. 95, and he shows the tricks of the trade on how to fall safely. Let's watch the video.
Elliot Royce falls down in front of groups of people. Watch him in slow motion. He's doing this for a very important reason. He's not clumsy. He's falling down over and over again, 14,000 times at last count, because he wants to teach seniors how to fall down safely.
As long as seniors are going to fall, I'm going to fall. Why shouldn't I learn how to fall?
Here's how he tells people to fall. Bend, twist, and roll. He shows it over and over again. He says falling on trampolines with supervised guidance also helps him. He does this 3 days a week.
See, I've fallen hundreds and hundreds and hundreds of times in here, and the more you fall, the more you overcome the fear of falling. It's the fear of falling that causes people to put their arms out, stiffen, and take body blows. break their bones.
I'm amazed that he's 95 and doing this, and he's just showing me what the possibilities are for my age and what I can do in getting older. I mean, his mother was almost 108 when she died. So we've got longevity in the family on his side, and he's showing us what the possibilities are. He's amazing.
Royce hopes slippery sidewalks and middle-of-the-night trips to the bathroom don't injure older people, as long as they know how to handle it as they're coming down.
Tuck, turn, and roll. Tuck, turn, and roll. All right. You'll have this access to this video too, because it's in the PowerPoint. You'll be able to view this again and share it with your staff. Inside the home, kinds of things. You can scan down through that. Adequate, no glare. Boy, glare is so. It's like putting your hand over your eyes almost, okay? Or holding wax paper up over your eyes. You can't see clearly. All right, make sure that you clear out the barriers. You don't have the leg rests on your wheelchairs, those kinds of things. Monitoring systems. We're getting better and better and better at technology. Technology is becoming very fanciful. It's able to predict and notify before the occurrence. We're getting there. We're slow. It's expensive, but we're getting there. Okay? And be very specific. And when you go into the dining room, watch for these things. When you get out of your chair, make sure that you use both of the armrests, okay? Now, what about inside? Flooring. Look at it. We've talked about some of this stuff. We mentioned the pile height. We talked about the transition spots. And even the patterns that we pick sometimes can be confusing for some eyes. The furniture, bed height matters. Different discussion, more time. You can set that. All you got to do is indicate on the wall behind the headboard at the height, just a little dot, the height that the bed should be set at. All right? All of those things, and be careful of casters on chairs, because they can be deadly. If you're going to push up on it and there's casters on all four legs, you have a problem. Now, what about just outside? What kinds of things outside? All of those. Parking lot, especially if you've got winter and ice and those kinds of things. Sidewalks, also after winter, sometimes you get heaving. And teach your residents how to get out of the vehicle safely. Sometimes they're going to need somebody to be there with them. What kind of reduction goals can we have? Well, minimize frequency and severity. Absolutely customer satisfaction. But if you keep them safe, you're going to have higher satisfaction scores too. But then also think about strength. Strength and endurance, two different words. What kind of tactics can we use? How do you minimize? Correct installation of products. You have good staffing there at the right kind of times. Good communications. And you're seeking intended consequence. Know what you want out of the outcomes. And we think, we just want fewer falls. Well, it goes deeper than that, because it's also the severity of the fall and the frequency and the surfaces and a discussion of all the things we've been carrying on today. Technology, it's amazing changes. Used to be a thermometer. It told you what the temperature was. Then a thermostat. It controlled something. Now we download this information. There's all kinds of analysis that goes on behind the scenes. And now we're even having where it comes out and it tells us about how to respond in advance of. Technology is amazingly more effective and efficient. And here's some of the ways the technologies we thought about for years. I think those are ones that we will see very powerful influences on the frequency of falls. Very powerful influences, okay? Level setting, person-centered care. Here's 4 resident-based fundamentals for person-centered care transition. All right, we need to be able to listen to people, to each other, to the resident. We need to engage the resident. We talked about more meaningful activities during the day, but also in their care themselves. Let them do whatever they can do. That which you do for me, you take from me. Maria Montessori said that, and it's never more true than in a nursing home. Make sure your documentation, not just the decisions you made, but also the interventions, and make sure that you go back and you continue to analyze your interventions. Why weren't they effective? What can we do? What can we adjust? And then make sure that people know about the things that are going on. All right. Again, level setting. Somebody's got to be the cheerleader. Somebody's got to make sure we stay with it. How many times have you rolled out a new program and 6 months later it's like it was never there before? When you recruit, you're looking for somebody that's enthusiastic and has energy and wants to be, have you ever met that person who just never stopped? The caring, the smile is there. Oh, yeah, the smile. Be consistent. Practice empathy. Great videos out there on empathy. Great training that can be done. It's a good awareness factor with your staff. All right. So it's the end. These are the things we talked about. But I've got one last video.
I was asked 5 years ago to speak to 3,000 employees of a large grocery store chain, and they brought everybody. After I'd spoken, I always give my home phone number to every audience. I had a young man who called me, and he told me his name was Johnny, that he was a bagger in one of the stores, and he was a person of Down syndrome. He said, "Barbara, I liked what you said." And he said he went home that night and he asked his dad to help him with the computer. And he said we set the computer up into 3 columns. And he said from that night on, every night that he goes home, he finds a thought for the day. And he said, if I can't find one I like, I think one up. Then he and his dad type it 6 times on a page. He prints out 50 pages every single night, cuts them out, signs his name on the back. And the next day, for every person's groceries he bags, he puts a thought for the day in the bag. Now, about a month later, the store manager called me. He said, "Barbara, I want to tell you what happened this morning." He said, "When I went out on the floor about 9:30 this morning, the line at Johnny's checkout was 3 times longer than any other line." He said, "I went ballistic. I was yelling, 'Get more people out there, get more lanes open.'" And he said, the customer said, no, we want to be in Johnny's lane. We want the thought for the day." So who do you think is the most important person in that whole store? He said, one woman came up and said, "I only used to shop once a week, but now I come in every time I go by because I want the thought for the day." He said 3 months later, the store manager called me back again, and he said, "Barbara, you and Johnny have transformed our store." He said, "Now in the floral department, when they have a broken off flower or an unused corsage, we used to just throw them away." He said, "Now they go out on the floor and they find an elderly woman or a little girl and they pin it on them." He said, "One of our meat packers loves Snoopy, so we ordered 50,000 Snoopy stickers. And every time he packages a piece of meat, his meat gets a Snoopy sticker on it." Now I said, "I don't know about dog stickers on meat." But he said, "We are having so much fun, and our customers are having so much fun." And folks, that's a true leader. And if he can do it, there is no reason why every one of us in this room and out there in our audiences can't do it. Thank you. God bless.
Okay. So how important are your people? Very important. You can't do this yourself. It's got to be an enterprise-wide effort, and I hope this helped. I hope there were things here of value. We're going to turn the camera over to Savannah for a minute or two.
And now for those interested in learning about the fall prevention products that Direct Supply offers, please welcome our product consultant, Renee Bayeski.
Hi, thank you so much, Savannah. So I am here, again, my name is Renee Bayeski, our clinical product consultant, to walk you through some popular products that we sell here at Direct Supply to really help when we think about falls and how do we best prepare our residents for some of those instances. The first product that we talk about here is called Move More, and it's really for lower extremity strength. The thing that I like best about this product is, one, the versatility. So it offers multi-directional resistance. The resistance is done similar to what we see with TheraBand, so adjustments can be made underneath the board, really promoting strength in both hips, knees, ankles, and feet, so helping a lot of areas. Lightweight and portable. You can see how easy it is to carry around, carry from room to room, store. One of the best things that I like about this, however, is you can see on that bottom right photo the concept of group exercise. So everyone, not everyone, but a lot of people, think the horrible E word, exercise, and I don't want to do that, or I don't want to go to therapy. So perhaps we organize and design an environment that we can help strengthen the resident, but make it more fun and make it something like Ray was talking about, something they want to do. So instead of going to the therapy room, setting them in a corner, having them move more, perhaps we get a group together, put some music on, sit more in a common room, and work on doing some of these activities that this can offer, but in a more fun group setting, so it doesn't seem like the evil E word, the evil exercise word that many think. The second product that we'll talk about is reducing injury reduction. This is a product from Impact Active, and these are hip protectors. So we've all seen a hip protector in the market before. This isn't really any different in the concept of it. Pads on the side and a garment that the resident wears. What Impact Active has really done that we see different in the industry compared to what our standard hip protector is really working on areas of the garment itself that will help improve compliance. So hip protection, there is tons of studies out there that show that it works and it is effective and it helps reduce injury, but it's only if it's worn. And if the resident keeps it on, and if the pads stay where they're supposed to stay, on the side of the hips, and if any of those things are different or any of those things get tampered with, then it's not really going to be effective and it's not going to help us reduce that injury. Some of those things that Impact Active has done to help improve that and help improve that compliance is, one, sewing the pad into the actual garment itself. So that hip pad that you see on the side there can never be removed. It won't get lost in laundry. Residents cannot remove or hide it. It's always going to be in place and ready to be used if it's needed during a fall. They also do a variety of garments. The two that you see here is an example of a men's and a women's brief. The idea being comfort and making it something that a resident will wear. A garment that they're familiar with, something that they've maybe worn almost their entire life. The only difference is thin pads on the side versus a generic garment that is maybe expected to be worn by both men and women and isn't as comfortable. Last but certainly not least, offering just a different choice in color. You can see the black and the white, and then making sure that that pad is flexible, thin, and can't really be seen underneath the clothing itself. No resident wants to be walking around a building with big bulky hip pads, essentially with a big red flag that says, I'm at fall risk, I have to wear these. No one wants that. So making it thin, concealing it underneath the actual clothing itself, and it'll help with that compliance. Residents will wear them, they will want to wear them, and they will keep them on so it can protect them during fall. This is one of my favorite products when we think about exercise and what's a piece of equipment that we can use in a rehab gym. This product is from SciFit, and we are all familiar with the SciFit steppers, so helping with that lower leg strength. This is a little bit different where it helps with lateral stability. So it looks like a stepper, but really the concept of this machine is you rotate your legs in circles. So both of those sides there will do a circular motion and pattern, which is really building strength on the outside of the legs versus the stepper up on the thighs and down the center of the leg, really helping improve that lateral stability. So when we're feeling uneasy and then they're swaying, the residents swaying from left to right, what piece of equipment can be different and innovative to really help strengthen that particular area for those residents? And that's the SciFit Latitude. From an assistance standpoint, we have the Rift and Tram. This has been in the market for a couple years now, so some of you might be familiar or have seen the Rift and Tram before. This product is really unique where it acts in a couple different ways. So first and foremost, we can use it as a sit-to-stand lift in the photo that you see depicted here. So the concept being that I can use some small slings, the harness around the body to really help the resident from a sitting to standing position. From there, this can also be used as a gait trainer. So the resident can hold on to the handles that the gentleman is and do some assisted walking. The caregiver can hold the front and help them that way. And it really provides gaining some of that confidence for both the resident while providing the right level of protection from the caregiver. So we don't need 3 caregivers anymore to help this gentleman maybe stand up and walk around and walk down the hallway. Now we really need 1, and the rest of it is done and supported by the lift itself. So better safety for staff, and a better way to be able to build confidence in residents when we're thinking of getting them back up on their feet and moving around the building using that Rift and Tram. Last but certainly not least, the last product that we'll talk about is engagement and exercise from Gentronics. This is a computer-based system that you can see there. The idea being that it's a whole built-out program that provides us a lot of ways that we can do first upfront assessment, so to understand what is going on with our particular resident, where are some of their areas of weakness and areas that they would be more likely to fall. Is it left, forward, backward? What does that look like? And then how can I use that information to better tailor what exercise programs, what rehab areas, and things like that do we need to focus on in order to make sure that we are getting them back up to be the best that they can be. It does that assessment, then it does some exercise things from a rehab perspective, and it also does some engagement and some fun games and ways to, again, make that E word, the exercise word, more fun. I'm skiing down a hill, I'm walking through a jungle, different things like that, versus being put on a machine and kind of just being left there to maybe do a stepper for 30 minutes. The nice thing about Gentronics is there is a couple ways that we can do it. This one on the upper left, you can see that the unit itself is on wheels, so we can very easily take that around the building if we need to. And it provides different ways to do that therapy for different resident needs. We see a gentleman standing. We see another lady that's sitting. This can also be used for people that are in the supine or laying position. So if we need to take this to a resident room that can't even get out of bed yet, there are different exercises and programs and ways to engage a large variety of audience based off of that particular need. So that's Gentronics that we can bring to help residents move forward.
Thank you so much, Renee, for that great demonstration, and thank you again, Ray, for presenting our webinar today. If you have any questions about the information you heard or the products discussed, please reach out to Joellen.